So, good evening, everyone. A warm welcome to you all for today's evening program on behalf of the Indian Academy of Pediatrics, Thrissur branch. Microbial resistance, a ticking time bomb, is the topic of the day. Indian Academy of Pediatrics is committed to proper antibiotic stewardship. We IAPians will be celebrating National Antibiotic Day on September 28th, which coincides with the historic day that Alexander Fleming discovered penicillin. Since then, so many powerful antibiotics have been discovered, but alas, due to misuse, we have started having also the emergence of multi-drug resistant diseases like TB, typhoid, etc. So indeed, it is very imperative that we have awareness programs like these, like the one we have today. So today we have inauguration of the Antimicrobial Awareness Week at the level of district level by the Thrissur IAP branch, and tomorrow is the state level inauguration. Our inauguration today of the Antimicrobial Week Awareness Program is at the hands of Dr. Bhagwati Ammai, who is a retired principal and HOD of Pharmacology at Government Medical College, Thrissur. A warm welcome to you, Madam. The keynote address was to be by our beloved State IAP President, Dr. Jairam. Committed to proper antibiotic usage, Dr. Jayaraman has been trying to emphasize the importance of setting up a proper antibiogram sensitivity in each district by proper surveillance. So hearty welcome, sir, if you are present among us. Today we have felicitations by Dr. Johnny Sebastian, who's the State Secretary IAP, and also by Dr. Shiva Prasad, who's the chairperson of the State Antimicrobial Resistance Board. Welcome to both sirs. The inaugural program will be followed by the CME. Our speaker on the topic, antimicrobial drug resistance, a ticking time bomb, will be delivered by Dr. Soumya Ramdas, who is a lecturer in pharmacology at Palagat Medical College. This year, the WHO theme is Spread Awareness, Stop Resistance. So, Madam, we await to hear more on the topic. Welcome to today's program. Our moderator for today is Dr. Ananda Keshwan, Additional Professor of Pediatrics at Government Medical College, and he is an integral member and advisor of most of our IAP programs at Thrissur. Hearty welcome to you and thank you, sir, for always being there with us. Well, regarding our academics at Thrissur, last Tuesday we had an excellent program in collaboration with Amla Medical College regarding the Childhood Cancer Awareness Month program. And coming up next, this Sunday at 5 p.m., we have the IAP PG Kozhikode Divisional Quiz, which is being held by the IAP Thrissur. So the program is at 5 p.m. Do attend, all of you. And next Thursday, we have the state level, that is 30th of this month, we have the state level valedictory function on antimicrobial awareness. And the talk is by none other than an excellent speaker, Dr. Baswaraj, on the use of antibiotics in PICU. So do attend all, and let's move on to the next leg of the program. I invite Dr. Bhagwati Ammai, Madam, to inaugurate the program.
And unmute, Madam. Unmute, Madam. Unmute. Sheet unmute me, Madam.
Madam, our side in the Madam mute. And unmute him.
Click here, Madam. Unmute.
Okay. Sally. Continue. Address. Shall I? Shall I?
Yes, madam. Yes,
Am
madam.
I audible?
Yeah.
I'm happy to know that the Indian Academy of Pediatrics Thrissur branch is organizing a meeting, antibiotic awareness meeting. Since I hope most of them participants are doctors, they will know what is an antibiotic. I need not explain that. Dr. Rathi also introduced about Dr. Alexander Fleming, who found out penicillin. We can trace the observation made by Dr. Paul Ehrlich, who found out that the growth of one introduction of one microorganisms will kill the other microorganism. And decades later, only Dr. Alexander Fleming found out that staphylococci can be inhibited by the contaminants of the penicillium. So we are using so many antibiotics for fungal, bacterial, and viral infections. But we know we had to. We are using antibiotics that we have to know in detail what the speakers has to tell and enlighten us in this meeting. I take this opportunity to thank Dr. Ananda Keshavan, who requested me to inaugurate this function. And I also thank the other organizers of IAP.
Thank you, madam.
I think there is a problem with the
Yeah.
madam's connection.
We'll continue, madam. We'll continue, madam. Thank you, madam.
So I think we will move to our
Branch.
Okay.
So I think we can move to the next program. The madam has already inaugurated our today's program, and thank madam for inaugurating our district level antibiotic awareness week program. And next we have our keynote address. I think our president is not joined now. So I invite Dr. Johnny Sebastian, sir, the state IAP secretary, for the felicitation. Johnny Sebastian, sir.
Thank you, Dr. Srijit. Good evening, all. Respected Chair, Dr. Raji Madam, Secretary Dr. Srijit, Chief Guest of the Day, Professor Bhagavati Ammal, Retired Principal, HOD Pharmacology, GMC Thrissur, Ananda Keshavan Sir, Past National Vice President, Advisor and Guide of IAP Thrissur, and a well-wisher of mine, my friend and Chairperson of Presidential Action Plan, Dr. Shiva Prasad, esteemed speaker, Dr. Saumya, seniors, and my dear colleagues. At the outset, let me congratulate IAP Thrissur for arranging this webinar as part of Antibiotic Awareness Week. And let me also express my heartfelt gratitude for coming forward to host the state valedictory function next week as well. As we all know, we need to increase awareness of global antimicrobial resistance and to encourage best practices among the general public, health workers, and policymakers to avoid further emergence and spread of drug-resistant infections. So to enlighten us, we have a very good speaker today. I wish this webinar all success and all the participants a great learning experience. Thank you. Jai Hind, Jai IAP.
Thank you, Johnny sir. Next, I invite my friend Dr. Shiva Prasad for the felicitation. He's the Chief of Antibiotic Awareness Program of IAP.
Respected senior members, dear friends, as we know that IAP Kerala is a strategical partner for government for implementing AMR action plan, and Thrissur IAP also always leading in front. And also I thank to our dear Anandakeshwan sir. Under his leadership, we have conducted around 7 web series of AMR program, awareness program. And I wish all the success to this program. And also I'm very happy that we are including our today's topic was also interesting topic. And also during the last meeting with the officials minister during the last meeting action plan, very much stress on the importance of involvement pharmacology department. And even from the CM office, Sri Datan sir, the scientific advisor to Honorable CM, also told the importance of involvement of pharmacy and also pharmacology department in AMR action plan. And also it's a very good step by our IAP Thrissur, and I wish all the success to this program. Thank you.
Okay, thank you, dear Shiva Prasad. And now we have our senior-most member of IAP Thrissur, Dr. V.K. Parvati Madam also joined. So I request Parvati Madam to say a few words.
Good evening to all. Am I audible?
Yeah, madam.
Yes, madam.
I am back in Thrissur, and it's very nice to see you all. Hope we will be able to see in person in the near future. So antibiotic resistance, we are hearing it for quite a long time. And to tell us about this, we have a young Soumya Ramadas to enlighten us. So all the best for the program. All the best. Thank you.
Thank you, madam. Now we will go to the CME program. For that, I invite to Dr. Anandakeshwan sir, our Professor of Pediatrics in Government Medical College, Thrissur, to moderate this session. So welcome Anandakeshwan sir to take over the proceedings from here. Okay.
Good evening, respected Chairperson Dr. Edhi Shantakumar. This evening, Chief Guest Bhavati Amma Madam, past IAP State President V.K. Parvati Madam, Dr. Ravindran from Kannur, Dr. Johnny Sebastian, Dr. Shiva Prasad, Dr. Srijit, other senior members of the IAP family. As I said, I would like to congratulate IAP Thrissur for organizing so many programs in connection with the various days and weeks. As already mentioned, this year the theme is that improve, spread the awareness and stop resistance. Even in 1942, Alexander Fleming discovered penicillin. He warned about the resistance about antibiotics to bacteria. He himself warned in future we are going to face a big problem. Even though more than 40 antibiotics are there in pipeline, I think a majority of them we cannot use routinely because of the adverse effect, resistance and everything. So we are really facing. WHO also warned the entire country that is the problem of antibiotic resistance. So antibiotic resistance is a problem every year because it's not only due to medical practice for humans, but agriculture, veterinary purpose, everything it is a problem. So it may be due to misuse, overuse, abuse, and whatever. And also a problem with a country like India, the problem is that two important problems. One is that the poor quality of antibiotic. So the chance for getting antibiotic resistance is very high. Second is over-the-counter prescription. That's another problem which is increasing. So it is our right time to concentrate on preventive measures in the form of vaccination and other preventive strategies. I think that is more important because now more and more organisms, I think almost all organisms are resistant to one or other antibiotics. So we are facing a big problem. Anyway, I am not going to detail. We have an excellent speaker, Soumya Ramadas. She is my student. I am proud to say she is my student. And also he completed his MBBS, MD pharmacology from Thrissur Medical College only. Then he had worked here also for 1 year. And she also got a PG diploma in clinical bioethics from PG Medical College Coimbatore. And she is very interested in bioethics and also antibiotic resistance and pharmacoeconomics. I used to keep a constant touch with Dr. Soumya for various to discuss various aspects of the clinical pharmacology. With this few introduction, I invite Dr. Soumya to deliver her talk. Over to Dr. Soumya.
Thank you, sir, for the kind introduction. At the outset, I would like to thank the Indian Academy of Pediatrics Thrissur branch and especially Dr. Anandakeshwaran sir for giving me this opportunity to speak on the very relevant topic of antibiotic resistance at present times. So without further delay, we'll move into the topic because already everybody has talked too much about it. Is the screen visible?
Visible and audible also, no problem. Everything going smoothly.
Okay. So the topic is antibiotic resistance, a ticking time bomb. In the early 1900s, there was no cure or any drug for infectious disease, and the human suffering due to that was immense. Infectious disease was the leading cause of mortality. Almost 90% of the children who contracted meningitis died, and those who survived were left with lifelong disability. In World War I, it is believed that more soldiers died of wound infection than due to the bullets. So this was truly, the pre-antibiotic era was truly the dark age. In 1928, Sir Alexander Fleming came up with this molecule, penicillin. It saved lives, it saved millions of lives during that time. And during World War II, it was used widespread and lots of lives of soldiers were saved. And it was hailed as the magic bullet or the miracle drug. The discovery of antibacterials were perhaps one of the most significant discoveries in the history of modern medicine that changed the course of our lives. Following the discovery of penicillin, a lot of new antibacterials came into the market. And this dark age was pushed by the antibiotics, and this ushered in the golden era of modern medicine. So during his acceptance speech, when he got his Nobel Prize, Sir Alexander Fleming had himself warned of drug resistance. After penicillin came into market, it was during the 1940s. Soon, within 1 or 2 years, first drug-resistant strain of Staphylococcus was isolated. So this is just, a comic representing. Initially, the bacteria were susceptible to the antibiotic. Later on, with continued use, it became resistant. So during the period of 1940 and 1960, a lot of new class of antibiotics came into the market. Penicillin already came. Then there was tetracyclines, chloramphenicol, aminoglycosides, pleuromucilins, macrolides. A lot of new classes of antibiotics came into the market. Following 1960s, there was a lull. Very few new class of antibacterials came into the market. And the ones which came into the market were purely Me Too drugs. Me Too drugs are the ones which don't have any added advantage. They're just like the previous antibiotics. They just like, Me Too drugs. They don't have any added advantage. And following 1990s, you can see there's a great discovery void. There are very few antibiotics, new classes of antibiotics that came into the market. Probably this is because, the drug industry, what happens to make a molecule come into market, it takes around 50 to 20 years and millions of dollars for one molecule to come out. But within a short period, the drug comes into the market, there is drug resistance. So these drug industries or the pharmaceutical industries have no guarantee that they're going to recover the money that they have spent. So the drug industry is naturally not interested in, investing their money in, antibiotics. So that perhaps explains the great void. There are very few molecules that has come following, 1990s. So that is one of a major public health concern. So these are some of the resistant bacteria that we are facing right now, right from carbapenem-resistant Enterobacteriaceae, vancomycin-resistant Staphylococcus aureus, vancomycin-resistant Enterococcus, multi-drug-resistant tuberculosis. You have a lot of resistant bacteria that are there, which are very difficult to treat. So the problem of drug resistance is staring right at us. We are actually in the middle of a global health crisis that we need to address and act. So infectious disease right now is the second leading cause of death. According to a report in 2019, 7 million people die every year due to drug-resistant bacteria. And it is projected that by 2050, almost 10 million people would die every year due to drug-resistant bacteria. That means one person dies every 3 seconds. That's a great number. So if you think the scenario in India is better, it's not so. The super problem is more in India than globally. This is the same newspaper clipping from the same date, okay, November 18, 2018. So we are losing our ammunitions against bacterial infections. And what I'm trying to say is we are being pushed back into pre-antibiotic era. That means a simple wound infection or a simple sore throat or a simple cut can mean a death sentence to us. So what is the impact of antimicrobial resistance? Antimicrobial resistance would mean increase of mortality and morbidity. That means treatment failures and longer period of infectivity. That would further enhance, drug resistance. And this is like a vicious cycle. You have to use more antibiotics, and again, that would predispose to drug resistance. And by 2030, it is projected that almost, a lot of people will be pushed into extreme poverty due to drug resistance. And you're losing almost 7% of the world GDP due to antimicrobial resistance because of the out-of-pocket expenditure. So what do you mean by antimicrobial resistance? Antimicrobial resistance is unresponsiveness of a microorganism to an antimicrobial agent. So this resistance can be transferred from an infected person to another person or from bacterium to bacterium. So these microorganisms are highly adaptable organisms when you compare them with human beings. They follow the Darwinian principle of selection. And they kind of, develop stringent mechanisms and methods to avoid lethal effects of antimicrobial agents. So so what are the types of antimicrobial resistance? You have natural, intrinsic, or innate resistance, or acquired resistance. So what do you mean by natural or intrinsic resistance? So natural or intrinsic resistance is because of the genetic makeup, the structure, or the physiological state of microorganisms. Say, for example, mycoplasma. Mycoplasma is cell wall deficient. So this organism is innately resistant to a cell wall synthesis inhibitor like beta-lactamase. Similarly, anaerobic organisms. Your aminoglycosides require an oxygen-dependent pump to enter into the bacteria. Anaerobic organisms don't have oxygen. So that means your aminoglycosides are innately resistant to anaerobic organisms. Similarly, vancomycin. Vancomycin acts, again, as a cell wall synthesis inhibitors. It requires peptidoglycan. So in gram-negative organism, peptidoglycan layer is quite thin. So again, it makes it quite resistant to gram-negative organism. And Klebsiella. Klebsiella has naturally got beta-lactamases. So penicillin group like ampicillin is resistant to Klebsiella naturally. But innate resistance or your natural resistance is not much of a public health concern because when these drugs came into market, at that time itself, it was not sensitive. So it's not big a public health concern. It does not have much of clinical significance. Whereas in acquired resistance is that one organism was previously sensitive to one drug, but after some time it became resistant. So organism which was sensitive to a drug now becomes resistant to the drug. This is a major concern and a public health problem. This is mainly due to widespread or irrational use of antimicrobials. So how do bacteria acquire resistance? So basically it can be due to mutations or horizontal gene transfer. And because of these mutations and gene transfer, bacteria, develop some biochemical mechanisms by which it becomes resistant. So we'll look into it in a bit more detail. So firstly we'll look into mutation. In any group of organisms which was sensitive, there will be a small group, in this I have denoted it as split, that would be resistant to the drug. With continued use of antimicrobial agents, what happens is that your drug-sensitive bacteria are killed off, leaving the drug-resistant bacteria, to proliferate. So with continued use of antimicrobial agents, what happens is your drug-resistant bacteria proliferates. This type of mutation, the transfer occurs vertically, that is from the mother to the daughter bacteria. One of the examples is methicillin-resistant Staph aureus. And this kind of mutation is a slow, it's not a rapid process, it's a slow grade, and usually the mutations or the resistance are low-grade resistance. Now, examples of horizontal gene transfer, this can be chromosomal or extrachromosomal by means of plasmid. The most common means of transfer is conjugation. Conjugation is the bacterial equivalent of sex. Bacterium 1, which has a drug-resistant gene, would attach to bacterium 2, which is not resistant, which is a sensitive bacterium, via sex pilus. And during this, it passes on the resistant gene from the bacterium 1 to the bacterium 2, making bacterium 2 resistant. So this is the means of transfer of resistance. Another one is transduction. That is my means of bacteriophages. So bacteria have their own viral flu, their own version of viral flu. Just like human beings get viral infection, bacteria also get viral infection. And the viruses that infect the bacteria are called as bacteriophages. And these bacteriophages, while infecting a resistant bacteria, can pick up some resistant genes from the resistant bacteria. And when it infects another bacteria, it can transfer on these genes to the second bacteria. This process is called as transduction. Here, the transfer of genetic material occurs with the help of bacteriophages. Lastly, there is something called as transformation. Suppose a resistant bacterium dies. So the resistant genes kind of leaks out to the environment, and another bacterium which was previously sensitive can take up this genetic material and become resistant. So these are the major means of horizontal gene transfer. So basically what happens is with the horizontal gene transfer, the spread is very rapid. So we saw that during mutation, the spread was very slow and low grade. Whereas when it comes to horizontal gene transfer, the spread of resistance is quite rapid, and usually the bacterium develops high level of resistance. So the thing is, the resistance is transferred not only between the same class of bacteria, it can be transferred from different class of bacteria also. Say, for example, vancomycin resistance is transferred from Enterococcus to Staphylococcus. So resistance gene can be transferred between different classes of bacteria also. Now, by means of all these resistance, what happens is now your bacteria has become resistant, and there are different means or biochemical mechanisms by which it becomes resistant. So one of the mechanisms is prevention of drug accumulation or entry. Say, for example, you have a porin channel. So usually your aminoglycosides enter via porin channels. And if suppose the porin channel is mutated, there is some change of shape. So your aminoglycosides cannot enter. So it prevents drug accumulation and entry, thereby making aminoglycosides inactive. Again, another method is modification of drug, target site. One of the classic example is modification of penicillin binding proteins. So that makes it methicillin resistant Staph aureus. So that is example for the target site modification. Then drug efflux. Say the drug has entered the bacterium. Once it enters, it is pumped out. So usually tetracycline resistance is like that. So tetracycline enters the bacterium, but it is soon pumped out. So again, it becomes ineffective. Then there are drug inactivating enzymes like your beta-lactamases. So your beta-lactam, bring a slice. So your beta-lactam antibiotics becomes ineffective. Then there is use of alternative metabolic pathways. Say, for example, your sulfonamides. Sulfonamides do not use preformed folic acid like you and I. They synthesize their own folic acid via, not sulfonamides, and some bacteria, sorry. Bacteria synthesize their own folic acid via PABA and charoic acid. Okay. So what happens when these bacteria develop sulfonamide resistance? What happens is they start using preformed folic acid, or they increase the levels of PABA, thereby overcoming sulfonamide resistance. And there can be formation of biofilms. Biofilms are formed usually when you have a medical implant or some infections like cystic fibrosis or endocarditis. What happens is these bacteria remains dormant inside these biofilms, and your antibiotic cannot penetrate into the biofilms, and these remain, resistant to the antibiotics. Then quorum sensing. Quorum sensing is just like bacteria's own social networking site. Okay, so these bacteria communicate with one another, and they pass information about drug resistance to a group of organisms. So it's their own mechanism of social networking and passing on information about drug resistance. So these are the different biochemical mechanisms by which your bacteria becomes resistant to antibacterial agents. So this was a molecular mechanism of drug resistance, but we are more interested in understanding how we are contributing, you and I are contributing to antibacterial resistance. So one of the major concern is antibiotic misuse or abuse. In our country, especially, you have very easy availability of antibiotic drugs. You can get it over the counter without any prescription. You go to a pharmacy and you can get antibiotics. You can get any antibiotics, say for that matter. Another thing is the antibiotics you get might not be, of good quality. They might be substandard, spurious, counterfeit medicines. And you might be given the wrong dose, wrong drug, wrong duration, and you might be taking antibiotics for viral infections. The other thing, if suppose you got the right drug, right duration, right dose, you might not stick to the course. Once a patient becomes, asymptomatic, he starts feeling better, he'll think, what is the need of taking the antibiotics? He'll stop it. So poor adherence. All of these things contribute to drug resistance. Then the other thing is indiscriminate use of antibacterial agents in farming and agriculture industries. It is believed that in US, almost 80% of the antibacterials that are sold are used in farming, agriculture, and poultry industry. So what happens is that even drugs like colistin is being used. Colistin is being used in poultry, and they're used as growth promoters. So what happens is these animals are exposed to antibacterials for a long period of time. So just like you and I, they also develop drug resistance, and they would pass on these excreta or whatever, and that could also have this drug resistant bacteria. It can contaminate your water bodies. So very water that you drink can be contaminated with drug resistant bacteria. Then the same their excreta might be used as manures or fertilizers, manures and fertilizers in agriculture. So again, your food that you take might be again contaminated with drug resistant bacteria. The very air that we breathe is, everything is contaminated. You don't have proper waste disposal or sanitation or sewage disposal methods. So this all aggravates or, add on to the problem of drug resistance. Then another issue is overpopulation, like in a country like us. So it's very easy for spread of infection. And nowadays, moreover, you have increased international travels. Again, that's a risk factor for spread of drug-resistant bacteria. Then as already mentioned, poor sanitation, poor waste disposal, poor sewage management, all these things would contribute to drug-resistant bacteria. And finally, your personal care products, like even, some toothpaste have antibacterial agents, and these antibacterial agents would be in sub-inhibitory doses that would further aggravate the problem of drug resistance. So there is a problem, and we need to, how can we tackle this problem of antimicrobial resistance? So that is a question at hand. So this was the theme of WHO in 2011. No action today, there is no cure tomorrow. So what are the actions that can be taken? See, antibacterials are one group of drugs. See, if I am taking an antibacterial drug or an antibiotic, it can affect the effectiveness in some other person. Okay, because say, for example, in my life, I have never taken an antibiotic. That doesn't mean that if I get an infection and I take an antibiotic, I would be, sensitive. My body is going to respond. There is no guarantee like that, because somebody else might be taking a lot of antibiotics and he would have passed the drug resistant bacteria to me. So even though I have never used antibiotics, I have the chance of getting a drug-resistant bacterial infections. So when you make an action plan against antimicrobial resistance, it has to have a global impact. It has to have a global perspective. So the action plan would require an action at the international level, the national level, at the community level, hospital level, at individual level, at the level of healthcare providers, and at patient level. So at the international level, we need increased collaboration between various governments, non-governmental organizations, non-profit organizations, and various private bodies and organizations like World Health Organization. And there should be networks for, these bodies should form networks for surveillance of antimicrobial use and provide adequate data on antimicrobial resistance. And there should be some regulatory body that controls the counterfeit antimicrobials. And there should be some incentives that should be given. I told you, because your drug industries or the pharmaceutical industries are not very interested in bringing out newer antimicrobial molecules because of the risk of resistance. So these organizations like your WHO, I think other organizations like the WHO should and other world bodies and governments should give incentives for research and development of new antibacterial drugs and vaccines. And they should have proper programs to contain antimicrobial resistance. At the national level, India have a national action plan for antibiotic resistance, which was a 5-year plan that was formulated in 2017. And the plan is to monitor the impact of antimicrobial resistance and provide intersectoral coordination. We have a proper formulation of antimicrobial resistance policy and making prescription only availability of antimicrobials. And there is a plan to make it legally binding for the manufacturers to give their distribution data to the government as and when required. And incentives, giving incentives for rational use of antimicrobials and bringing out national standard treatment guidelines based on the antibiogram. Okay, so for, just like you have standard treatment guidelines for your tuberculosis infection, you can have standard treatment guidelines for other infections as well. So there can be a national strategy or an action plan to have treatment guidelines for common infectious diseases, and enhancing coverage of immunizations and regulating the use of antibiotics in agriculture and poultry. At the community level, you need to have proper infection prevention strategies, ensuring proper vaccination coverage, ensuring healthcare and proper sanitation and proper waste disposal, and regular educational programs, both for patients as well as the doctors, and awareness on antimicrobial resistance. As a healthcare practitioner, what one can do is comply with the standard treatment guidelines wherever it's possible and always avoid irrational use of antibiotics. And as far as the patients are concerned, they should be educated on the menace of antimicrobial resistance. They should avoid self-medication on antibiotics, adhere to the antibiotic treatment regimen. If they're given an antibiotic for 7 days, they should continue the treatment for 7 days. And as of now, you have to break the chain of infectivity. So anybody who is having some infection, they have to isolate themselves and prevent further spread of infection to the community and their family members. So at the hospital level, you have the antibiotic stewardship program or the antimicrobial stewardship program. So what do you mean by antimicrobial stewardship program? It's a coordinated intervention designed to improve and measure the appropriate use of antimicrobial agents. So basically the intention is to ensure rational use of antimicrobial agents by promoting optimal, the right antimicrobial drug at the right dose, for the right duration, and the right route of administration. So basically the antimicrobial stewardship itself means protection. So antimicrobial stewardship means protection of antibiotics. So you are kind of ensuring that you give the right or the correct antimicrobial drug for the right dose, right duration, and for the by right route of administration. So what are the basic goals of a stewardship program? So the basic goal is to optimize safe and appropriate use of antimicrobial agents to improve clinical outcomes as well as to minimize the adverse drug reactions, reduce antimicrobial resistance, thereby reducing the healthcare costs, and reduce antibiotic-induced collateral damage. That means if you're taking antibiotic, if you're taking a broad spectrum damage, the collateral damages your normal flora would be inhibited and might be predisposing you to a Clostridium difficile infection. So reduce antibiotic-induced collateral damage. So what is an antimicrobial stewardship team? Basically, it should have an infectious disease expert, a clinician, a clinical microbiologist, a clinical pharmacologist, an epidemiologist, and a technician for technical support. So what are the elements of antimicrobial stewardship program? Basically, you have two strategies. One is prospective audit with feedback intervention and formulary restriction or pre-authorization. What do you mean by prospective audit? Prospective audit is not actually given by the healthcare provider. If I am prescribing the drug, I am not auditing it after some. I am not auditing it. It is a stewardship team that audits. It audits the prescription and ensure that you're given the right choice of antimicrobials at the right dose for the right duration and right route of administration. And based on that, they would give a feedback. It can be given directly to the person or via some meetings. So basically, this is something that might not be, entertained by the clinicians. They would feel that somebody else, this infectious disease expert, is putting his nose into my thing. I'm losing my autonomy. Things like that would, everybody is bound to feel that he's questioning my clinical judgment. Things like that. But everybody needs to be educated because we are doing all this for the larger good. The other mechanism is formulary restriction or pre-authorization. In this, as the name itself suggests, certain group of drugs, say for example, carbapenem or colistin, it cannot be just like that prescribed. You need to have a pre-authorization form. You need to get prescription for prescribing certain drugs that need to be protected. So that means formulary restriction, pre-authorization. So to use certain groups of antimicrobial agents, you need to get permission from the stewardship team before you use it. So one of the disadvantage of this is it can, increase the treatment duration, unnecessary delay, and all these things. You need a proper stewardship team. You need to have quite resourceful. You need to have expertise at every level. Only then these things is possible. Now, the other thing that you can do to have a proper stewardship program is to give proper education. This education can be given to the healthcare providers and to the patients. You can have, give these pamphlets with educational, suppose you have a new antimicrobial drug or you have a new antimicrobial resistance, you need to pass on the information, or you have a new treatment guideline. These information can be passed on via pamphlets, or you can have CMEs like what we are having. So this means you can spread these information, and this information can be given to the doctors as well as to the patients. Then the other is you can have a facility-specific treatment guideline based on the, the local antibiogram. You would have your own sensitivity pattern in your healthcare facility. So based on that, you need to formulate a standard treatment guideline for your facility that is tailor-made for your facility. So this is WHO aware classification database. So based on this, they have included almost 180 antibiotics. Some of them are included in the access group that is available free of use. These group of drugs have low predisposition to develop resistance. So they are included in the access group. Then you have some drugs which are included in the watch group. And there are some drugs which are in the reserve group. The ones with reserve group are to be protected, and they need to be used only for multi-drug resistant infections. Okay. So when you have your own hospital drug formulary, you can have a reference of the WHO aware classification database and have a drug formulary of your own hospital. Apart from that, there is something called as antibiotic cycling. What do you mean by antibiotic cycling? This is scheduled removal of a specific class of antimicrobial resistance to prevent or reverse the development of resistance. So there are limited studies to support. Just like that, you remove a particular antibiotic for a particular period of time, so that by means of which you try to achieve that you want to circumvent the resistance. You believe that after some time, if you're not using that antibiotic, after some time, the microorganism would become sensitive to this drug again. So one of the data that supports this is, sulfonamides was used left and right, and following which there was widespread resistance to sulfonamides. But what happened is sulfonamides is one drug which can cause serious adverse drug reactions like Stevens-Johnson syndrome. So what happened is once you had safer alternatives of antimicrobials that came into market, what happened is people started, they did not rely on sulfonamides anymore. So sulfonamides was not used very often. And because of which, after some time, it was noted that the organisms which were previously, which became resistant to sulfonamides are now sensitive. So based on this, this is believed that once you stop using an antimicrobial for a particular period of time, after some time, the organisms can probably become sensitive to it. Okay, so that is the rationale of antimicrobial cycling. Then you can have something called as antibiotic order forms, or what do you mean by an antibiotic order form? So this is, I don't know how much this is clear. This is an antibiotic order form. So basically, you don't have to use an antibiotic order form when you are facing a life-threatening infections like a intra-abdominal abscess or a meningitis or intracranial abscess or anything. But if suppose for common infections, you need to write what is the aim of your prescribing of antibiotic, whether it's for prophylactic use or whether it is for therapeutic use. You need to mention the dose, the route, the duration of the drug. So usually what happens in our ICU setup, we go on writing, repeat 1, 2, 3. So antimicrobial can go on forever and ever. Okay. So in this, what happens is when you have a proper antibiotic form, there is automatic stop. So after the particular duration, the antibiotics would be stopped. And you need to mention if the patient is having any history of drug allergy, whether he's having any renal impairment or hepatic impairment. So based on that, the stewardship team can, adjust the dosage, and if it needs to be, they need to change the antibiotic, it can be done like that. So the most important thing is that this is believed that once you start using antibiotic order forms, what happens is the use of antimicrobials naturally decreases, because always you need to mention what is the reason why you are using antimicrobials. Now, the other thing is de-escalation or streamlining. So when you start an antimicrobial, what happens is you start with empirical therapy, and most of the empirical therapy is usually broad spectrum. Okay, so because you don't have the culture and sensitivity report, you start with an empirical or a broad spectrum antibiotic. But after 48 hours, or when your culture and sensitivity report comes, there is a chance that you can de-escalate or streamline your antimicrobial from a broad spectrum to a narrow spectrum or a targeted therapy. Okay, so you need to see whether there is a response. You need to see if there is a response. If we have started on with the empirical therapy, whether the patient is responding. If the patient is not responding, definitely you have to change the drug. And if suppose the patient is responding, then you have to think whether you can de-escalate, whether you can, once you get the culture and sensitivity report, whether you can shift on to a more narrow spectrum or a targeted therapy. And once you have shifted to a targeted therapy, you need to ensure that you are giving a right dose, right duration, you're giving the right route of administration. And every time you need to see that de-escalation is possible or not. Always try to de-escalate. Always try to de-escalate from a broad spectrum to a narrow spectrum antibiotic. Now, switching over from parenteral to oral therapy. So if suppose a patient, starts getting better, he can take on oral feeds. It's always better to switch over from a parenteral to oral therapy, because that would, decrease adverse effects, phlebitis and things, thrombophlebitis and things like that from the parenteral therapy. And many of your drugs like linazole, it has very good oral bioavailability. So it can be very easily switched on to oral therapy. Okay. So your aim should be to de-escalate from a broad spectrum antimicrobial agent to a narrow spectrum antimicrobial agent, and to shift over from a parenteral to oral therapy. And what are the other strategies? You need an information technology team. You need a technical support for a proper antimicrobial stewardship program. You need expert computer clinician, clinical decision support system. This support system would help you with, these standard treatment guidelines would change on from time to time, and this would help the clinician to remain updated, and it would support the decision making. And again, you can have computerized physician order entry and purely electronic medical entry. Okay, medical records. This is one thing that can revolutionize your antimicrobial surveillance program. So once you have everything, suppose it's recorded electronically, what happens is all your data is available at a fingertip. Okay, so you can monitor how much of antibiotics has been used, what dose has been used, how much reserve group antibiotics has been used, what is the percentage, what is the cultural sensitivity, everything is available at fingertips. And if suppose you have a drug-drug interaction, it can be alerted like that. So this is something that we need to go in, this electronic medical record system. So if suppose somebody has a drug allergy, everything would be recorded. So next time you prescribe the same drug, you get an alert that this patient has a drug allergy. So this is something that is going to revolutionize the field and something that would help us in surveillance. Then what is the role of the microbiology laboratory? So of course, they are the ones who perform the susceptibility. They are involved in diagnostic as well as they're involved in susceptibility testing. So nowadays, with the advent of molecular diagnostic, it's very, you get your diagnosis very quickly. For some organisms like tuberculosis bacteria, which requires a lot of time for culture, with the advent of molecular diagnostic, within a very short time, you can get the diagnosis, and whether you can also know to what drug your mycobacterium is resistant. So molecular diagnosis has got a big role to play. And the microbiologist who's reporting the sensitivity, he or she can restrict. Suppose he need not test the sensitivity for reserve group of drugs, and he or she need not report it. If suppose the drug is sensitive to colistin, he need not report it. If it's sensitive to a lower antibacterial drug, he can report that. He need not mention it is sensitive to colistin. In this way, this can prevent people, clinician from using that. So he can prevent reporting reserve group of drugs. So that is one way microbiologists can help. And what are the outcome measures? How do you measure whether all your strategies are working or not? So one of the things that you can measure is the percentage of antimicrobial drugs that were prescribed when you compare it to the other drugs. The percentage of reserve group of drugs, reserve group of antimicrobials that is prescribed. The defined daily doses. That's of course not possible for the pediatric age group because you don't give the defined daily dose for adults. But anyway, that is one of the outcome measures that you can measure. The dose, the duration, all these things would give you a good idea about how your program is working, whether there is a reduction in the prescription of antimicrobial agents, whether there is a reduction in prescription of reserve group of drugs. All this would give you a fair idea about how your program is working. So we have, all these strategies, all these things are there. Okay. So all these things are very good in the paper, but our country, how difficult it is to implement these strategies. So unless and until you have new drugs, it's not going to, work for us. So is there a light at the end of the tunnel? Is there any new antimicrobials in the pipeline? Of course, there are some antimicrobials. So these are some of the newer antimicrobials that are there in the pipelines. You have fidaxomicin, which is approved recently for Clostridium difficile infections. You have all these glycopeptides like dalbavancin, tilavancin, oritavancin, ramoplanin. They came for methicillin resistant, vancomycin resistant Staph aureus, daptomycin. Then ketolites like solithromycin. Then radisolid and taurizolid, which are analogs of linezolid. They come from the same group. These are some of the newer drugs. Then you have fifth generation cephalosporins, which are active against methicillin-resistant Staph aureus. Then you have a newer drug that is cefiderocol. Cefiderocol is a cephalosporin with a siderophore, moiety that is active against carbapenem-resistant organism. Then you have newer aminoglycoside like plazomycin. Then newer beta-lactamase inhibitors like vaborbactam. This is a combination of neuropenem, vaborbactam, ceftolozane. All these are reserve drugs. Ceftolozane, tazobactam, aztreonam, avibactam. These are some of the newer drugs. And this drug that is soliflodacin. Soliflodacin is approved for drug-resistant gonorrhea infection, which is a topoisomerase 2 inhibitor. Usually you have topoisomerase 4 or DNA gyrase inhibitor. This is a topoisomerase 2 inhibitor. And this drug, interestingly, this is a WHO funded drug. Okay. So there are some future targets on which we are working. Okay, novel antimicrobials from nature, from the herbal or the plants. Then antimicrobial peptides from vertebrates, invertebrates, and other microorganisms. Then targeted delivery, just like your amphotericin, you have liposomal or delivery through nanoparticles. Then quorum sensing inhibitors. I told you about the social networking of antimicrobials. You have quorum sensing inhibitors like furanons and garlic extract that can help in reducing drug resistance. Then already available antimicrobials, you can modify their structure and arrive at other antimicrobials which are better. Then drug repurposing, like some of the antidepressant agents are being tried, looked on for their antibacterial activity. In that way, you don't have to go through the safety trials because already these drugs have been used for long time. So only you need to do efficacy trials. Okay. So that is called as drug repurposing. Already the drugs which are used for some other purpose are being tried in for, they're looking for their antibacterial activity. Then developing newer vaccines for bacterial infections. Then even biologics are being, looked upon for bacterial infections. Then phage therapy, that is another target, for bacterial infections in the future. So thank you, everybody.
Thank you, Dr. Samia. Thank you, Samia, for the excellent discussion. Antibiotic, I already mentioned, is a double-edged weapon. It saved many lives, but still a problem of antibiotic resistance. I think even though Soumya mentioned about the national, international level, I think self-auditing is very important, whether we are to use it or not. And once sensitive pattern is we got it, we should be ready to stop it anytime, because we'll get a sensitive report after 3-4 days, then we continue the same antibiotic. That should not happen. We have to stop it at any time. And also mentioned about latest aspects, newer antibiotics, and also medical molecular diagnosis, and she touched, I think, almost all topics. 2-3 questions. Is there a questions chat box? See, 2-3 questions from my side is one is we mentioned about the antibiotic resistance to poultry use, and mentioned we read somewhere it's used for growth promoter. How antibiotic is using as a growth promoter in poultry? It is read everywhere, many times. How it is affecting this growth promoter?
I think what I understand is basically probably, when you give antibiotics, they won't get infected much. Maybe that is the reason they are used as growth promoters. That is my understanding on this.
I think almost all medical societies, either for pediatric or medical, we are bringing with the antibiotic, rational use of antibiotics therapy for different, but still we are not following. Is there any legal? Say primary care physician can use this much of antibiotic, specialist can use this much of antibiotic, because we are seeing alike, means primary physician using almost all antibiotics, and in a medical college setup, tertiary care setup, specialist using same antibiotic. Is there any legal action, something like that, any country like that? Any awareness for that?
I'm not sure about any legal action, but in many of the countries, you need to have, a pre-authorization before you prescribe. Some of the countries are practicing that. So you need to get, the approval from the stewardship team to get your prescriptions done. So anyway, suppose you're prescribing an irrational antibiotics, the stewardship team would act on that and prevent irrational use of antibiotics. In our country, definitely there is nothing like that. Even you and I can go to the pharmacy and just name the antibiotic and we can get it. So that is a problem in our country, but I'm not sure about any legal action on use of antibiotics, but probably the stewardship team can act, suppose there is a pre-authorization or a pre-authorization needed. So in that way, it can be acted upon.
One question is about irrational antibiotic combination. That's one problem because different combination. And also, I think WHO approved only for amoxicillin clavinic acid, some specific combination. But now we can see so many cephalosporin combining with so many combination, and also irrational combination means ofloxacin combined with so many anaerobic medications. So many irrational combinations there. So how it will lead to antibiotic resistance? See,
one of the irrational combinations, it's very commonly prescribed, especially in ear infections and things like that, is ampicillin cloxacillin. And here, the ampicillin cloxacillin mixture, ampicillin is only 250 milligram. So this is purely an irrational combination. Cloxacillin is a beta-lactamase resistant beta-lactam. There is no need to combine both of them. If suppose you are suspecting a beta-lactamase producing organism, you can purely give only cloxacillin. So when you combine ampicillin and cloxacillin, you're giving both of them in subtherapeutic doses. So this is one of the irrational combinations that I have come across most of the times. So WHO has taken strict action against, they have given guidance against irrational combinations, and we also need to comply on that. Unnecessarily avoid combination of drugs, because especially in drug, say in infections like tuberculosis and leprosy, you are left with no other option. You have to give a combination of antimicrobial agents. But otherwise, in endocarditis, again, you might have to give a combination of drugs. And otherwise, you can look at the sensitivity pattern and stick to just one agent. You need not give two agents. So avoid combinations as far as possible. That is a guidance from the antimicrobial, based on the antimicrobial stewardship program. You need not combine drugs just like that, unless and until it is necessary. So basically, when you combine drugs, it's like your empirical therapy. You want to combine both the gram-positive, gram-negative anaerobes. You start with a, it's like a blanket cover. But once you get the sensitivity pattern, what you need to do is, you need to streamline and de-escalate.
I think a few days back, we had some announcement by Kerala Health Minister. CURSAP, means Kerala Antimicrobial Persistent Resistant Strategic Action Plan. Means Mayalthu പറഞ്ഞ 2023 സമ്പൂർണ്ണ antibiotic സാക്ഷരത. I think we have about Shiva Prasad from Ernakulam. He is chairman of the state committee for the IAP, chairman for the antibiotic stewardship. Shiva Prasad, can you talk about something about the CURSAP? If possible, you can open your video. If video, can you open video?
സാറ് ചോദിച്ചിട്ട് നല്ലൊരു ക്വസ്റ്റ്യൻ ആണ്. അതിനെ പറ്റി നല്ലൊരു പ്രസന്റേഷൻ ആയിരുന്നു മാഡത്തിന്റെ. അത് എങ്ങനെയാണ് ഈ ഗ്രോത്ത് മോട്ടർ ഇത് ഉപയോഗിക്കുന്നത് അന്വേഷണം സാർ ചോദിച്ച വളരെ ഒരു നല്ലൊരു ചോദ്യമാണ്. അപ്പൊ അത് ഞാൻ ഐ വിൽ ട്രൈ ടു എക്സ്പ്ലെയിൻ ഇറ്റ്. കാരണം വെച്ചാല് നേരത്തെ സ്പീക്കർ പറഞ്ഞ പോലെ തന്നെ 80% ഓഫ് ആന്റിബയോട്ടിക് യൂസ്ഡ് ഇൻ USA യൂസ്ഡ് ഫോർ വെറ്ററിനറി പർപ്പസ്. From Europe, 70% of manufacturing antibiotics are used for veterinary purpose as a growth promoter. India, exact data but it is the higher side. The growth promoter is active the broad spectrum antibiotic, the cholesterol and high-end antibiotics it will destroy the industrial bacteria. Cattle poultry industrial bacteria destroy. അപ്പൊ അതിനാവശ്യത്തിനുള്ള ഈ കാറ്റിലും മറ്റേ പോൾട്രി ചിക്കൻ പോലെ സാധനങ്ങൾ പെട്ടെന്ന് ഫാറ്റ് ആവുകയും ചെയ്യും, പെട്ടെന്ന് ഗ്രോ ചെയ്യും, ഫാറ്റ് ആവുകയും ചെയ്യും. അതാണ് അതിന്റെ മെക്കാനിസം. അങ്ങനെയാണ് ഈ ഇൻഡസ്ട്രി തന്നെ ഇത് ഉപയോഗിക്കാൻ കാരണം. അപ്പൊ നമുക്കറിയാം, നമ്മുടെ മോഡേൺ മെഡിസിൻ ഡോക്ടറുടെ ഗ്ലോബലി നോക്കുകയാണെങ്കിൽ ഇറ്റ്സ് ലെസ് ദാൻ 20%. നമ്മൾ വിചാരിക്കും നമ്മുടെ ഇറേഷണൽ പ്രിസ്ക്രിപ്ഷൻ ഒക്കെ ഉണ്ട്, പക്ഷെ അതിനേക്കാൾ ഉപരിയായിട്ട് ആന്റിബയോട്ടിക് യൂസേജ് ഇൻ ദ പോൾട്രി അല്ലെങ്കിൽ നമുക്കൊരു വെറ്ററിനറി പ്രാക്ടീസ് ആണ് ഏറ്റവും ഇമ്പോർട്ടന്റ് ആയിട്ട് ഒരു AMR ക്രൈസിസിൽ വരുന്നത്. അപ്പൊ ഇത് ഈ ഗ്രോത്ത് പ്രൊമോട്ടറായിട്ട് ഇത് ഉപയോഗിക്കാനുള്ള ഒരു ബേസിസ്, അതായത് ഒരു സയന്റിഫിക് റീസൺ ഇതാണ്. ഇങ്ങനെയാണ് അത് എക്സ്പ്ലനേഷൻ വരുന്നത്. രണ്ടാമത് സാറ് നേരത്തെ പറഞ്ഞ പോലെ തന്നെ ഈ AMR പ്രോഗ്രാം എന്ന് പറയുമ്പോഴത്തേക്ക് വൺ ഹെൽത്ത് അപ്രോച്ചിലാണ് കാര്യങ്ങളിൽ നമുക്ക് നീക്കേണ്ടത്. കാരണം നമുക്കറിയാം ഒരു മോഡേൺ മെഡിസിൻ ഡോക്ടറുടെ കോൺട്രിബ്യൂഷൻ അല്ലെങ്കിൽ നമുക്കൊരു 20% അടുത്തേ വരുന്നുള്ളൂ. ബാക്കി 80% ഡീൽ ബൈ അഗ്രി, ഫിഷറീസ്, വെറ്റിനറി മുതലായ ഈവൻ ഹണി. നമുക്കറിയാം, നമുക്ക് കൊച്ചുകുട്ടികൾ കൊടുക്കുന്ന ഹണിയിൽ പോലും, തേനിൽ പോലും ആന്റിബയോട്ടിക് റെസിഡ്യൂ കണ്ടെത്തിയാണ് സെന്റർ ഫോർ സയൻസ് ആൻഡ് എൻവയോൺമെന്റ് എന്നുള്ള ഡൽഹിയിലുള്ള സ്ഥാപനം കണ്ടെത്തിയിട്ടുള്ളത്. അപ്പം അത് കാരണം എങ്ങനെ കണ്ടെത്തി, അങ്ങനെ ഉപയോഗിച്ചു വെച്ചാൽ ഈ മറ്റേ തേനീച്ച വരാതിരിക്കാൻ വേണ്ടി ആന്റിബയോട്ടിക്കിന്റെ റെസിഡ്യൂ സ്പ്രേ ചെയ്യും. അങ്ങനെയാണ് ഈ ഹണിയിൽ വരുന്നത്. അപ്പൊ അത്രത്തോളമാണ് യൂസേജ് വരുന്നത്. അപ്പൊ നേരത്തെ സാറ് സൂചിപ്പിച്ചാൽ കർസാപ്പ്, അതിനകത്ത് കേരള ആന്റിബയോട്ടിക് റെസിസ്റ്റൻസ് സ്ട്രാറ്റജി ആക്ഷൻ പ്ലാൻ എന്ന് പറഞ്ഞാൽ ഇന്ത്യയിൽ തന്നെ ഫസ്റ്റ് സ്റ്റേറ്റ് ഇൻ ഇന്ത്യ ടു റിലീസ് AMR ആക്ഷൻ പ്ലാൻ നമ്മുടെ കേരളമാണ്. കേരളത്തിനെ ഫോളോ ചെയ്തുകൊണ്ട് ഇപ്പൊ 7 സ്റ്റേറ്റ് അതിന്റെ മാതൃക കൊണ്ടുവരുന്നുകൊണ്ട് ആക്ഷൻ പ്ലാൻ ഉണ്ടാക്കുന്നുണ്ട്. ഈ ആക്ഷൻ പ്ലാനിൽ ഇപ്പൊ നമുക്ക് 2018 തുടങ്ങിയതാണ്, 2017 ഇതിന്റെ ആക്ടിവിറ്റീസ് തുടങ്ങിയത്, 2018 ആക്ഷൻ പ്ലാൻ ആയി. അത് ഇംപ്ലിമെന്റേഷൻ ലെവലോട്ട് വരികയാണ്. അപ്പൊ പല രീതിയിൽ ഇപ്പം എറണാകുളത്ത് ആന്റിബയോട്ടിക് സ്റ്റുവർഷിപ്പ് പ്രോഗ്രാം നമ്മൾ ഇവിടെ റൺ ചെയ്യുന്നുണ്ട്, ഹെൽത്ത് സർവീസ് റൺ ചെയ്യുന്നുണ്ട്, എല്ലാ മെഡിക്കൽ കോളേജിലും സർവേലൻസ് ചെയ്യുന്നുണ്ട്. നേരത്തെ ഈ ഇതിനകത്ത് ഒരു വൺ ഹെൽത്ത് രീതിയിൽ വരുമ്പോഴത്തേക്ക് എല്ലാ ഡിപ്പാർട്ട്മെന്റും ഉൾപ്പെടുത്തിക്കൊണ്ട് സാറ് അനന്തകേശവ സാർ നേരത്തെ സൂചിപ്പിച്ച പോലെ തന്നെ വെറ്റിനറി, അഗ്രി, ഫിഷറീസ്, പൊള്യൂഷൻ കൺട്രോൾ. അപ്പൊ അതൊക്കെ വളരെ ഇമ്പോർട്ടന്റ് ആണ്. നമ്മുടെ ഈ ഈവൻ നമ്മുടെ ലേക്കിലൊക്കെ വാട്ടർ എടുത്ത് നമ്മൾ നോക്കുമ്പോൾ ഇറ്റ് കണ്ടെയ്ൻസ് ഹൈലി റെസിസ്റ്റന്റ് ബാക്ടീരിയ കാണുന്നുണ്ട്. ഈവൻ ചെന്നൈയിൽ നടത്തിയ സ്റ്റഡിയിൽ കണ്ടെത്തിയത് നേരത്തെ നമ്മുടെ മാഡം പറഞ്ഞ പോലെ തന്നെ, സ്പീക്കറിലെ മാഡം പറഞ്ഞ പോലെ തന്നെ, ഫുഡ് പ്രൊഡക്റ്റ്, അതായത് മീറ്റ് പ്രൊഡക്റ്റ് പരിശോധിച്ചപ്പം ഇറ്റ് കണ്ടെയ്ൻസ് കൊളിസ്റ്റിൻ റെസിസ്റ്റന്റ് ബാക്ടീരിയ. ചെന്നൈയിൽ 60% ഓഫ് മീറ്റ് പ്രൊഡക്ട്സ് കണ്ടെയ്ൻസ്. നമ്മൾ വിൽക്കാൻ വെച്ചിരിക്കുന്ന മീറ്റ് പ്രൊഡക്റ്റിൽ അത്രയും സാധനങ്ങൾ കണ്ടു. അപ്പൊ അതിനകത്ത് തന്നെ അതിന്റെ ഇമ്പോർട്ടൻസ് എന്താ വെച്ചാൽ, ഇപ്പൊ നേരത്തെ മാഡം സൂചിപ്പിച്ച പോലെ തന്നെ പ്ലാസ്മിഡ് മീഡിയേറ്റഡ് AMR ആന്റിബയോട്ടിക് ട്രാൻസ്ഫർ ഉണ്ട്, അതുപോലെ ക്രോമോസോമൽ മീഡിയേറ്റർ ഉണ്ട്, ആന്റിബയോട്ടിക് ട്രാൻസ്ഫർ ഉണ്ട്. ഈ പ്ലാസ്മിഡ് മീഡിയേറ്റഡ് ആണെങ്കിൽ ഇറ്റ് ക്യാൻ ജംപ് ഫ്രം വൺ ബാക്ടീരിയ ടു അനദർ ബാക്ടീരിയ. ഈ കൊളസ്ട്രോൾ റെസിസ്റ്റന്റ് MCR ജീൻ ആണെങ്കിൽ ഇറ്റ് ക്യാൻ ജംപ് ഫ്രം ഈക്കോളി ടു ക്ലബ്. ക്രോമോസോമൽ മീഡിയേറ്റഡ് ആണെങ്കിൽ അതൊരു അതിന്റെ പ്രൊജനിക്ക് മാത്രമേ കൊടുക്കാൻ പറ്റുള്ളൂ. അപ്പൊ ഒരു ഫുഡ് പ്രൊഡക്റ്റിലും ഒരു വൺ ഹെൽത്ത് എന്നുള്ള ഒരു കൺസെപ്റ്റിലോട്ട് വന്നാൽ മാത്രമേ നമുക്ക് കറക്റ്റ് ആയിട്ടൊരു AMR ആക്ഷൻ പ്ലാനിൽ ഇംപ്ലിമെന്റ് ചെയ്യാൻ പറ്റും. നമ്മുടെ ഒരു കോൺട്രിബ്യൂഷൻ എന്ന് പറഞ്ഞാൽ സാറ് നേരത്തെ പറഞ്ഞ പോലെ തന്നെ നമ്മുടെ IAPയെ സംബന്ധിച്ചോളം IAPയുടെ ഏറ്റവും ലീഡർ റോളിൽ നിൽക്കുന്ന ആളാണ് അനന്തകേശവൻ സാറ്. സാറ് തന്നെ ഇത്രയും വെബ് സീരീസ് നമ്മൾ നടത്തിയിട്ടുണ്ട്. ഇറ്റ് വിൽ ഹെൽപ്പ് ദ പ്രിസ്ക്രിപ്ഷൻ പാറ്റേൺ. നമ്മുടെ ഒരു AMR പ്രോഗ്രാമിന്റെ ഒരു എൻഡ് റിസൾട്ട് എന്നാൽ നമ്മുടെ ഒരു ഡോക്ടർ പ്രിസ്ക്രൈബ് ചെയ്യുമ്പോൾ you should think about what is prescribed. അപ്പൊ അതിനെ കുറിച്ച് ഒരു വ്യക്തമായ അതിന്റെ ഒരു സെൻസിറ്റീവ് ആണോ, ഇത് റേഷണൽ ആണോ, ഇത് ഇറേഷണൽ കോമ്പിനേഷൻ ആണോ. നേരത്തെ സാറ് സൂചിപ്പിച്ചാൽ ഒരുപാട് ഇറേഷണൽ കോമ്പിനേഷൻസ് വരുന്നുണ്ട്. അതല്ല നമ്മുടെ എല്ലാ പുതിയ ജനറേഷൻ ഡോക്ടർമാര് പലപ്പോഴും മെഡിക്കൽ റെപ്പ് എന്ന് പറയുമ്പോഴത്തേക്ക് അത് എഴുതുന്ന ഒരു പ്രവണതയുണ്ട്. അപ്പൊ ആ പ്രവണതയെല്ലാം മാറ്റി ഒരു കണ്ടിന്യൂസ് ട്രെയിനിങ് പ്രോഗ്രാം, അതാണ് ഈ കർസാപ്പിൽ വരുന്നത്. കർസാപ്പിന്റെ 6 പ്രയോറിറ്റീസ് ആണുള്ളത്. ഒന്ന് അവയർനെസ് ആൻഡ് അണ്ടർസ്റ്റാൻഡിങ്, അതാണ് ട്രെയിനിങ് പ്രോഗ്രാം. അതാണ് നമ്മുടെ IAP ചെയ്യുന്നത്. IAP is doing a lot of 2300 പീഡിയാട്രിഷ്യൻ ഓൾ ഓവർ കേരള they are giving training programs. രണ്ടാമത്തെ സർവൈലൻസ്, അതായത് നോളജ് ആൻഡ് എവിഡൻസ് എന്ന് പറയും, അതായത് ലാബ് സർവൈലൻസ്. അതിനാണ് നമ്മൾ മൈക്രോബയോളജിസ്റ്റിന്റെ ഏറ്റവും ഇമ്പോർട്ടൻറ്റ്. ക്ലിനിക്കൽ മൈക്രോബയോളജിസ്റ്റ് ഉണ്ടെങ്കിൽ മാത്രം ചെയ്യാൻ പറ്റുള്ളൂ. മൂന്നാമത്താണ് ഇൻഫെക്ഷൻ പ്രിവെൻഷൻ കൺട്രോൾ. നാലാമത്തെ റാഷണൽ ആന്റിബയോട്ടിക് തെറാപ്പി. റാഷണൽ ആന്റിബയോട്ടിക് തെറാപ്പിനകത്ത് തെറാപ്പിയിൽ ക്ലിനിക്കൽ ഫാർമക്കോളജി ഇന്റഗ്രൽ കോമൺ. പക്ഷേ അൺഫോർച്ചുനേറ്റ്ലി ക്ലിനിക്കൽ ഫാർമക്കോളജിസ്റ്റിന്റെ ഒരു സേവനോ അവരുടെ പ്രസൻസ് അതിനകത്തൊരു അത്ര നമ്മൾ വിചാരിക്കുന്ന ലെവലോട്ട് വരുന്നില്ല. അത് കഴിഞ്ഞ ഞാൻ നേരത്തെ സൂചിപ്പിച്ച് കഴിഞ്ഞ ഹെൽത്ത് മിനിസ്റ്റർ റിവ്യൂല് അത് വരിക സംസാരിക്കുകയുണ്ടായി. അപ്പൊ എന്നാൽ മാത്രമേ നമുക്കൊരു കറക്റ്റ് ആയിട്ട്, അതായത് മൈക്രോബയോളജിസ്റ്റിന് അതേപോലെ തന്നെ റോള് ഫാർമക്കോളജിസ്റ്റിനും ഉണ്ട്. മേ ബി ഹെൽത്ത് സർവീസിൽ കുറവാണ്, മെഡിക്കൽ കോളേജിൽ അഡിക്റ്റഡ് സ്റ്റാഫ് ഉണ്ട്. അപ്പൊ അവരും കൂടി ആ മേഖലയിലോട്ട് വരണം. അഞ്ചാമത്തെ കാര്യം റിസർച്ചാണ്. അതാണ് നമ്മൾ ചെയ്യുന്ന ആന്റിബയോട്ടിക് റിസർച്ച്. ഇപ്പൊ നമുക്ക് നമ്മുടെ മൈക്രോബയോളജി ഡിപ്പാർട്ട്മെന്റിലും പീഡിയാട്രിക്സ് നമ്മുടെ മെഡിസിൻ ഡിപ്പാർട്ട്മെന്റിലും ചെയ്യുന്നുണ്ട്. ക്യാൻ എക്സ്റ്റെൻഡ് ടു ദ അതർ ഡിപ്പാർട്ട്മെന്റ്സ് ഓൾസോ. നമ്മുടെ വെറ്റിനറി, അഗ്രി, ഫിഷറീസ്, ഏതാണ്ട് 40ഓളം പബ്ലിക്കേഷൻ കഴിഞ്ഞ 2018 ശേഷം ഈ നമ്മുടെ ഹെൽത്ത് ആൻഡ് വെറ്റിനറി, അഗ്രി, ഫിഷറീസ്, പൊല്യൂഷൻ കൺട്രോൾ ബോർഡ് ഇളക്കി കഴിഞ്ഞു. പിന്നെ ആറാമത്താണ് കൊളാബറേഷൻ. അതിലാണ് IAP ഇമ്പോർട്ടന്റ് സ്റ്റേക്ക് ഹോൾഡർ ഇൻ കണ്ടെയ്നിങ് AMR ആക്ഷൻ പ്ലാൻ ഓഫ് AMR കണ്ടെയ്ൻമെന്റ് ഓഫ് ദ സ്റ്റേറ്റ്. അതായത് IAP ഉണ്ട്, APA ഉണ്ട്, IMA ഉണ്ട്. അപ്പൊ അങ്ങനത്തെ പ്രൊഫഷണൽ IAP വളരെ ഇമ്പോർട്ടന്റ് റോൾ അത് ആക്ട് ചെയ്യുന്നുണ്ട്. സോ ഇറ്റ്സ് ആക്ച്വലി AMR ഈസ് നോട്ട് ഒരു ഹെൽത്ത് ഇഷ്യൂ അല്ല, ഹെൽത്ത് ഇഷ്യൂ മാത്രമല്ല, ഇറ്റ്സ് എ സോഷ്യോ എക്കണോമിക് പൊളിറ്റിക്കൽ ഇഷ്യൂ. നമുക്കതൊരു ഡിസ്കസ് ചെയ്യേണ്ട, ശരിക്കും ഇറ്റ് ഷുഡ് ബി ഡിസ്കസ് ഇൻ എ പ്ലാറ്റ്ഫോം വേർ പോളിസി മേക്കേഴ്സ് ആർ ദേർ, പൊളിറ്റീഷ്യൻസ് ദേർ, ബ്യൂറോക്രാറ്റ്സ് വേണം, നമുക്ക് ഡോക്ടേഴ്സ് വേണം, വെറ്ററിനറി എക്സ്പെർട്ട് വേണം, പൊല്യൂഷൻ കൺട്രോൾ എക്സ്പെർട്ട് വേണം, എൻവയോൺമെന്റൽ സയന്റിസ്റ്റ് വേണം. അപ്പൊ ഇങ്ങനെ ഒരു മൾട്ടി സെക്ടോറിയൽ നിൽക്കുന്ന ഒരു പ്രോഗ്രാമാണ്. അപ്പൊ ഇതൊരു ആക്ച്വലി ഇറ്റ്സ് എ സൈലന്റ് പ്രോഗ്രാം. ഇപ്പൊ നമ്മൾ തന്നെ ഒരുപാട് ട്രെയിനിങ് നടത്തുന്നുണ്ട് എല്ലാം. അപ്പൊ നമ്മുടെ ഈ എല്ലാ മേഖലയും ഒരു പ്ലാറ്റ്ഫോമിൽ വന്നാൽ മാത്രമേ നമ്മൾ ഉദ്ദേശിക്കുന്ന തലത്തിലോട്ട് വരും. കാരണം ഞാനത് പറയാൻ കാരണം 20% ലെസ് ദാൻ 20% പറയാൻ പറ്റും ദ കോൺട്രിബ്യൂഷൻ ഓഫ് ദ മോഡേൺ മെഡിസിൻ ഡോക്ടർ ഇൻ AMR ക്രൈസിസ് ഗ്ലോബലി. ബാക്കി 80% that should be deal with other specialty like veterinary, agri, pollution control. അപ്പൊ ഇത് അഫക്ട് ചെയ്യുന്ന ആരെയാണ്? അഫക്ട് ചെയ്യുന്നത് ഹ്യൂമൻ തന്നെയാണ്. അപ്പൊ അതിന് ചികിത്സിക്കേണ്ട ബാധ്യത ഡോക്ടേഴ്സിന് വരികയും ചെയ്യും. അപ്പൊ ഇതിനകത്ത് ഒരു വൺ ഹെൽത്ത് എന്നുള്ള ഒരു അപ്രോച്ചിൽ നിന്നാൽ മാത്രമേ നമുക്ക് ആന്റിബയോട്ടിക് റെസിസ്റ്റൻസ് എന്നുള്ള ഒരു പ്രതിഭാസത്തിന് നമുക്കത് ഒരു പരിധി വരെ ഒന്നും കൂടി സ്ട്രെസ് ചെയ്ത് പറയാം, ഒരു പരിധി വരെ നമുക്ക് തടയാൻ പറ്റുള്ളൂ. global economic crisis എന്ന് പറഞ്ഞാല് നമുക്കറിയാം it's a slow pandemic which is lurking behind COVID. അപ്പൊ ഇത് വെസ്റ്റേൺ കൺട്രിയിലൊക്കെ ഭയങ്കര ഇമ്പോർട്ടന്റ് ആണ്. ഇപ്പൊ നമ്മുടെ ഇന്ത്യയെ സംബന്ധിച്ചോളം ഇന്ത്യക്ക് എത്ര ഹോസ്പിറ്റൽ ഉണ്ട്? 75,000 hospitals all over India. But less than 1% running effective antibiotic distribution program. പക്ഷേ USA എടുത്തു നോക്കൂ, അവിടെ ഒരു നമ്മുടെ വെസ്റ്റേൺ കൺട്രീസ് എടുത്തു നോക്കൂ, 80% of hospitals are running some source or form of antibiotic distribution program. ഇപ്പൊ നമ്മൾ നേരത്തെ പറഞ്ഞ എക്സസ് യൂസ് ഓഫ് ആന്റിബയോട്ടിക്സ് ആണ് എന്താ പറയാ ആന്റിബയോട്ടിക് റെസിസ്റ്റൻസ് ഉണ്ട്. ഓക്കെ, ഐ അഗ്രി. പക്ഷെ അതിനേക്കാൾ ഉപരി ഇന്നബിലിറ്റി ടു അസസ് ദ ആന്റിബയോട്ടിക്. 33% പോപ്പുലേഷൻ ഇന്ത്യ ഇസ് നോട്ട് ഏബിൾ ടു അസസ് ആന്റിബയോട്ടിക്സ്. അതായത് വേറൊരു സത്യമാണത്. അപ്പൊ ഇൻഫെക്ഷൻ അവിടെ കൂടും തോറും അതിന്റെ ആ ഒരു ആന്റിബയോട്ടിക് റെസിസ്റ്റൻസ് കൂടും. അപ്പൊ നമുക്ക് ഇതൊരു ഡബിൾ എഡ്ജ് സാഡ് പോലെയാണ് നിൽക്കുന്നത്, ഒരു ഇരുതല മൂർച്ചയുള്ള വാള് പോലെയാണ്. അപ്പം ഒരു തലത്ത് എക്സസ് യൂസ് വരുമ്പോൾ ബാക്കി തലത്ത് ആന്റിബയോട്ടിക് അസസ് ചെയ്യാൻ പോലും പറ്റാത്ത സ്ഥിതിയിലോട്ടാണ് പോപ്പുലേഷൻ പോകുന്നത്. അങ്ങനെ ഇതിന് മൾട്ടി പർപ്പസ് ലെവലിൽ നിൽക്കുമ്പോൾ വി ഷുഡ് ഹാവ് നമുക്കൊരു മോറൽ റെസ്പോൺസിബിലിറ്റി ഉണ്ട്. ഇനി അടുത്ത ജനറേഷൻ ഇപ്പൊ 100 വർഷം കഴിഞ്ഞു, 1921 ആകുമ്പോൾ 100 വർഷത്തോളമായി ആന്റിബയോട്ടിക്കിന്റെ ഒരു ഹിസ്റ്ററി പരിശോധിക്കുക. ഇനി ഒരു പൈപ്പ് ലൈൻ ഓഫ് ആന്റിബയോട്ടിക്സ് കുറവാണ്. അപ്പൊ ഇനി അടുത്ത വാക്സിൻ പറഞ്ഞു. വാക്സിൻ ഓൾസോ ഇമ്പോർട്ടന്റ്. ഇപ്പൊ നമ്മളിപ്പോ ന്യൂമോകോക്കൽ വാക്സിൻ ഇൻട്രൊഡ്യൂസ് ചെയ്തു. ദാറ്റ് വാസ് എ വാക്സിൻ വിച്ച് വാസ് വെയിറ്റഡ് ബൈ ദ AMR ആക്ഷൻ പ്ലാൻ. കാരണം ന്യൂമോകോക്കൽ വാക്സിന് ഒരു പരിധി വരെ ന്യൂമോകോക്കൽ അല്ലെങ്കിൽ ബാക്ടീരിയൽ ഇൻഫെക്ഷൻ കൊണ്ടുള്ള ഡിസീസ് കുറയ്ക്കാൻ പറ്റും. ദാറ്റ് ഓൾസോ വിൽ ഹെൽപ്പ് ടു AMR ആക്ഷൻ പ്ലാൻ. But globally, Western countries are giving highest priority to this. അവരുടെ ഹെൽത്തിന്റെ പോളിസി തന്നെ വളരെ ഇമ്പോർട്ടന്റ് ആണ് ഉള്ളത്. കേരള ഹാസ് ടേക്കൺ എ മോഡൽ. നമുക്ക് ഒരുപാട് മുന്നോട്ട് പോകാനുണ്ട്. നമുക്ക് ഒരുപാട് ബാക്കിയുള്ള സ്റ്റേറ്റ് ആർ സ്റ്റഡിങ് വാട്ട് ഈസ് ഹാപ്പനിങ് ഇൻ കേരള. slowly our national other states also will gain the momentum of Kerala. But നമുക്ക് എന്താ പറയാ IAP is doing a wonderful job. കഴിഞ്ഞ health minister meeting very well appreciated by the action of the IAP, and especially thanks to അനന്തകേശവൻ സാർ. കാരണം എന്റെ ഗുരുവാണ് അനന്തകേശവൻ സാർ. കാരണം ഞാൻ 2014 തൊട്ടാണ് AMR ആക്ടിവിറ്റീസിലോട്ട് വന്നിട്ടുള്ളത്. പക്ഷെ നമുക്കറിയാം നമ്മുടെ ഈ കാര്യങ്ങളെല്ലാം IAP സംബന്ധിച്ചോളം ഒരുപാട് കാര്യങ്ങൾ ചെയ്യുന്ന മെഡിക്കൽ കോളേജിലും നമ്മുടെ ഒരു ജനറൽ പ്രാക്ടീഷണറും വളരെ സിൻസിയർ ആയിട്ട് സാധാരണ കാര്യങ്ങൾ ചെയ്യുന്നുണ്ട്. ദാറ്റ് ഈസ് എ റിമാർക്കബിൾ തിങ് ആണ്. ദാറ്റ് വാസ് വെൽ അപ്രീഷിയേറ്റഡ് ഇൻ ദ സ്റ്റേറ്റ് ലെവൽ ഓൾസോ. ഇറ്റ്സ് എ ടീം വർക്ക്. ആൻഡ് ഒരു കാര്യം ഞാൻ പറഞ്ഞ് നിർത്തുകയാണ്, മോഡേൺ മെഡിസിൻ ഡോക്ടറുടെ പ്രിസ്ക്രിപ്ഷൻ മാത്രമല്ല, we should approach in a one health aspect. എന്നാൽ മാത്രമേ നമുക്ക് ഇതിനെ കുറിച്ച് നമുക്ക് പ്രിവെന്റ് ചെയ്യാൻ പറ്റുള്ളൂ. നിർത്തുമ്പോൾ ഒരു കാര്യം കൂടി പറയാണ്, എമർജിങ് ആൻഡ് റീ എമർജിങ് വൈറൽ ഇൻഫെക്ഷൻ 60% ഓഫ് എമർജിങ് ആൻഡ് റീ എമർജിങ് വൈറൽ ഇൻഫെക്ഷൻസ് ആർ സൂനോട്ടിക്. അപ്പൊ 60% വരുന്ന വൈറൽ ഇൻഫെക്ഷൻ എമർജിങ്, നിപ്പയും കോവിഡ് അടക്കമുള്ളത് സൂനോട്ടിക് ആണ്. ആ സൂനോട്ടിക് ഡിസീസിനെ കൺട്രോൾ ചെയ്യണമെങ്കിൽ വൺ ഹെൽത്ത് അപ്രോച്ച് വേണം. വൺ ഹെൽത്ത് അപ്രോച്ച് ഉള്ള ഏക പ്രോഗ്രാം AMR പ്രോഗ്രാമാണ്. ആന്റിമൈക്രോബ് റെസിസ്റ്റന്റ് പ്രോഗ്രാം എന്ന് പറഞ്ഞാൽ ഇറ്റ്സ് നോട്ട് അറ്റ് ഓൾ ആന്റിബയോട്ടിക് യൂസേജ് മാത്രമല്ല, ഇറ്റ് ഹാസ് എ ബ്രോഡ് സ്പെക്ട്രം. ഇറ്റ് കവേഴ്സ് ദ ഇൻഫെക്ഷൻ പ്രിവെൻഷൻ കൺട്രോൾ ഓൾസോ. അപ്പൊ നമ്മൾ വളരെ നല്ല രീതിയിൽ IAP is moving forward, and Kerala is moving model to other state also. Thank you.
So thank you, Dr. Shivaprasad, for the valuable advice and also doing a wonderful work. I think state government is doing a wonderful work with the help of IAP. Now I request Dr. Parvati Madam mentioned about some routine drugs are not available nowadays. For example, cloxacillin, chloramphenicol, even quaternium is not available. And then lastly, even plain amoxicillin is not available. We are getting more and more combination. Parvati Madam, any comments, Madam? Parvati Madam, a strong pillar of antibiotic.
I have already written. Just like the speaker and Dr. Shivaprasad mentioned, a collaboration with other departments, this veterinary medicine and then poultry, everything all of them should act together. And why can't the drug controlling agency control the irrational combinations? Why can't they do it?
IP is very bad. In the pharmacopoeia, they are not doing, I think, very poor work. Any combination, any drug,
and the clinician should have rapport with the pharmacologist and microbiologist. That is one thing which we lack often. clinicians think that they are superior to all others.
Excuse me, one of the reason I think the Indian pharmacopoeia is not very interested is most of them are pharmacy people now. Even the drug controller general is pharmacy people. The pharmacology people are not coming up and taking up their post. So that is probably one of the reasons that they are not, into all these things much.
Any other comments from any other audience?
And the PDF, we hear so much about antibiotic resistance from DIAP, all platforms. Even then, how many of us practice what you preach is another thing. That is the most important thing. We will say antibiotic stewardship in the platform and then prescribe medicines irrationally. That is one thing which you should avoid.
നമ്മള് സ്ഥിരമായിട്ട് മന്ത്ലി സ്റ്റാറ്റിസിൽ ആന്റിബയോട്ടിക് യൂസ് കാണിക്കുന്നുണ്ട്. നമ്മള് ഭയങ്കര പ്രിസ്ക്രിപ്ഷനിൽ എത്രമാത്രം ആന്റിബയോട്ടിക് ഉപയോഗിക്കുന്നുണ്ട്. അപ്പൊ എത്ര കണ്ടീഷനിൽ ഭയങ്കര ഡ്രാസ്റ്റിക് റിഡക്ഷൻ ആന്റിബയോട്ടിക്
പ്രത്യേകിച്ച് പണ്ട് പറയാറുണ്ട്, നമ്മളെ തന്നെ ഒന്ന് നമ്മള് സെൽഫ് ഓഡിറ്റിംഗ്, ദാറ്റ് ഈസ് ദ ബെസ്റ്റ് തിങ്. ഒരു ദിവസം പ്രാക്ടീസ് കഴിഞ്ഞാൽ എത്ര പേർക്ക് ആന്റിബയോട്ടിക്സ് എഴുതി, എത്ര എണ്ണം ആവശ്യമായിരുന്നു, എത്ര എണ്ണം അവോയ്ഡ് ചെയ്യായിരുന്നു, അനാവശ്യമായിട്ട് നമ്മൾ എത്ര എണ്ണം ചെയ്തു എന്ന്. പേഷ്യൻസ് ചോദിക്കണമെന്ന് പറഞ്ഞാൽ അർത്ഥമില്ല, പാരന്റ്സ് ചോദിക്കണമെന്ന് പറഞ്ഞാൽ യാതൊരു അർത്ഥമില്ല. യു ആർ ദ പേഴ്സൺ ടു ഡിസൈഡ് വാട്ട് യു ഹാവ് ടു പ്രിസ്ക്രൈബ്, നോട്ട് ദ പാരന്റ്സ്. നോ പ്രഷർ ഫ്രം ദ പാരന്റ്സ് ഷുഡ് affect your prescription. That is one thing.
We create such awareness that and staff in my unit, they can write any drug without asking me, but antibiotic they have to ask me. That is the rule. Such a strict auditing we are doing.
It was a wonderful talk. I forgot to mention, it was a nice talk.
If there's no more comments, I would like to thank Dr. Soumya for the wonderful talk. And I invited Dr. Srijit.
ഒരു പോയിന്റ് കൂടെ പറഞ്ഞോട്ടെ.
Sure, sir.
ഇപ്പോൾ ഈ സിസ്റ്റംസ് തിങ്കിങ് എന്ന് പറഞ്ഞൊരു കൺസെപ്റ്റ് ഡെവലപ്പ് ചെയ്ത് വരുന്നുണ്ട്. അതായത് മൾട്ടി ഡയമെൻഷണൽ അപ്രോച്ച് വേണം. എനി പ്രോബ്ലം, ദിസ് പോവർട്ടി, ദിസ് വയലൻസ്, എക്സെട്ര, ഇതെല്ലാം സിസ്റ്റംസ് തിങ്കിങ്. അത് തന്നെയാണ് ഈ ബ്രസ്റ്റ് ഫീഡിങ്ങിനും പ്രോബ്ലം. ഒരു സയന്റിഫിക് തിങ്കിങ് മാത്രം പോരാ. There should be another thinking, systems thinking, which is multi-dimensional approach. അതാണ് നേരത്തെ പറഞ്ഞ വൺ ഹെൽത്ത് എല്ലാം അതിനകത്ത് വരും. Okay, thank you.
So over to Dr. Srijit for official vote of thanks.
So that comes to end of today's energetic discussions, and we have many new ideas and new thoughts from the speaker and all the participants. So I would thank the speaker of the day, Dr. Soumya Ramdas Madam, for the excellent and talk covering the session very well, and also thank Dr. Anandagasham sir for moderating the session, and I'll thank Dr. Bhagavati Amma Madam for inaugurating the session, and senior members Parvati Madam and Vinay Kuryakar sir and Johnny Sebastian sir, and my friend Shiv Prasad for joining this discussion. So hope you to see in another program. And we have the state valedictory function on September 30. So please do join us on that day also. So good night from IAP Thrissur, and thank you for joining us.
Good night. Thank you, Dr.